So it should be available to you and to lots of others. So if others you know are interested and weren't able to be here, we'll try to get that in place so that you can reference that and tell people about it. I do want to remind you that for credit to please fill out your evaluation forms. What Andy and I are going to do is set up a couple of chairs up here, have a little dialogue back and forth. We'll invite your participation, and then we'll wrap up.
Well, it's a pleasure to be back here in South Carolina again. This is one of the several trips that I've made. I've enjoyed every one of them in visiting with you, John, and speaking to members of the psychiatry community. And this is a good opportunity today to talk about some issues with family members. Let me just start out by saying, and I do want this to be conversational discussion and not really a debate, but people can chime in at any time. But is my speaking on?
I think he's on.
Am I being heard?
Yeah.
Okay, so maybe it was just under my tie. John mentioned that I've been appointed to be the head of the work group on personality disorders for the DSM-5 and on the task force of DSM-5. He actually mentioned Axis 2, the head of the Axis 2 committee. So that actually is the end of the discussion and debate, because if personality disorders go on Axis 1, I'll be out of a job. So we'll come back to that, though. I think it's very relevant that John used Axis 2 to refer to personality disorders. This process really hasn't even begun. The first meeting, the first organizational meeting of the task force is scheduled for the first couple of days of November of this coming November, next month. And so how the process is going to unfold, who the members of the work groups are going to be, et cetera, have not been determined. So no matter what sort of ideas I express here today about my sort of opinions about where personality disorders should be in the classification, I do want to emphasize that I have a very open mind. I mean, this is a process that's going to go on for at least 5 years, and I wouldn't want anybody to conclude that it was fixed in any way or determined, because it really isn't. And a lot of work, discussion, field trials, hopefully, clinician surveys, et cetera, will have to be done before any real decisions are made. So I do want to say that at the outset. Let's see. First of all, I think, it interests me that there are a number of people who have stayed to even hear this discussion, because you wouldn't think that most people, family members, would be that interested in the multi-axial system of DSM, which is kind of an esoteric part of the classification. But since you're here, I think it is important to just go over briefly what this is all about and why the DSM multi-axial system is as it is. Multi-axial diagnosis has been around in psychiatry for 50 or 60 years, with a basic rationale that mental disorders are very complex and hard to capture in single diagnostic categories, and therefore to adequately represent a person's psychopathology and functioning, more than one sort of rating or designation needs to be made. So in the DSM system, most clinical disorders were put on Axis 1. Mental retardation and personality disorders have been put on Axis 2. At one time, there were also learning disabilities on Axis 2, but they're now on Axis 1. Physical disorders in psychiatric patients are on axis 3. Axis 4 is for the stressors or environmental circumstances that are important for understanding the person's disorder, and axis 5 is the functioning axis. The rationale for putting PDs on axis 2 originally was there was the thought that they were somehow fundamentally different, and the difference was to be more chronic as opposed to episodic. But that distinction clearly doesn't fit either most or many axis 1 disorders, or, as it turns out, the PDs themselves. I always like to say that if that were the reason for, if chronicity and pervasive disturbance were the criteria for personality disorders, that schizophrenia would meet the criteria very nicely for a personality disorder. So there are many, as research has gone on, there's much research that has determined that many mood disorders, many anxiety disorders, as well as psychotic disorders and cognitive disorders, etc., are equally or even more chronic than some of the PDs seem to be. In recent years, both in Pat Cohen's study, Mary Zanarini's clinical study of borderline patients, and our collaborative study of borderline and 3 other types of PDs, we've shown that the course of PDs is much more fluctuating and less stable than the DSM definition would imply, and that's led us to try to tease out various aspects of personality that might be more stable versus more changeable. But that's another story, another talk. So PDs are, for better or for worse, are on axis 2, and I guess the question is, for this discussion, should they stay there? Should they not stay there? I think that one of the hard to argue with results of PDs having been put on axis 2 is the enormous amount of research attention that has been directed to PDs since this happened in 1980. I don't think that anybody would debate that having a special designation, having a special axis for PDs has encouraged the research explosion, if you will, that we've seen in borderline and other personality disorders, such that we now have much better ideas of the epidemiology of personality disorders, how common they are in general population, starting to get some data on the genetics of PDs, quite a bit on the concept of comorbidity, which we'll come back to its importance, and the development of treatments. I think that the idea that specific treatments can now be developed for addressing borderline and other PDs in a way that was not particularly appreciated 20, 25 years ago, I think has also been a positive byproduct of the research explosion. So, that I think that's a clear benefit of PDs having been on axis 2. Now, the question that is asked is, well, two questions. What are the downsides? And maybe I'll let John chime in with some of that. And also, has this axis 1, axis 2 distinction outlived its utility? It's had enough of an impact as it is, and do the downsides or the negatives now outweigh the positives? And I think that we can discuss that, and be interested in hearing some of your opinions about that too. But John, do you want to say something about how you now view the pros and the cons, and then I'll come back to some of the other issues, I think.
Sure. It's funny, John Livesey and I were talking at lunch yesterday, and some time ago, John Livesey and I were debating this issue at a program, I think it was the ISSPD, the International Personality Disorder Group, and he was on the side of we don't need axis 2 anymore. It's outlived its usefulness, and I was defending axis 2. So we've actually been asked to do a similar kind of dialogue or debate at the upcoming ISSPD conference in The Hague next year. And we have to sort that out as to who's on which side. So I was telling him that I had actually come to the position. Now, let me back up and say that John claims that he won that debate hands down, but it wasn't true. I clearly won the debate. And he was just wrong about that. But then I told him that even though I clearly won the debate at the time, he must have been persuasive because I've come around to his point of view at this point. So he took that as vindication that he was clearly right all along. So we have a lot of fun talking about it. I do think there are two issues. There are a lot of issues, but there are two that get conflated and confused sometimes. There's the question about whether we should continue to use a categorical system that's sort of a medical disease-based model, or shift to a dimensional system in the understanding that we've talked about here, that the personality disorders are part of a continuum that is pretty seamless all the way from variable types and styles, where you can do an MMPI type of chart that shows the ingredients that characterize a particular person, like an individual fingerprint of personality, to extremes of certain features that would then add up to what we would call disabling pathology and have labeled as a disorder. So that's one debate and a question. But I want to put that aside for a minute, because let's say we don't totally change the categorical system. We might revise it in some ways, and I think all of us would agree that there's a lot of revision that's needed. I don't understand what the rationale is that would prevent us from picking up the whole personality disorder group as a group, moving them over and putting them down in what we now call Axis 1. We then have to think about whether we still would need an Axis 2. Well, what would be inconsistent with the other categories of Axis 1 if we did that? We have the psychoses, the mood disorders, the anxiety disorders, the personality disorders. We could still list them all, but we would have them as a sort of protected, retained set of diagnoses, and I think that could lead to comparable continuity of research, comparable sort of clinical usage, as long as we had the basic sort of building blocks are still in place. Because of just some of the things, including the work that you've been one of the leaders with, which is the longitudinal data that have shown, but you probably should comment on that, because that's something that is a little bit bifurcated into sort of symptom episodic pictures versus steady traits. But at the same time, I think that there's not a persuasive argument that, to me, would differentiate what we now call the personality disorders on Axis 2 as a conceptual grouping from some other disorders on Axis 1, which I think you could make a persuasive case could be on that list, such as cyclothymia, dysthymic disorder, maybe eating disorders, maybe some other conditions that have the same sort of early onset, longitudinal, typical pattern over time. So,
okay. Well, so even if they're not fundamentally different, I mean, could we still think of, positive, beneficial effects of leaving the PDs on Axis 2? And recognition of PDs in clinical settings is, I think, it should be encouraged. I don't think that there's enough data. I wish there had been more research done about the actual impact of introducing Axis 2 personality disorders into the DSM system. In other words, a pre and a post 1980s type study. I mean, we've seen a few documentations now by Harold Konigsberg and Mark Zimmerman and others of the fact that PDs can be diagnosed with some frequency in outpatient settings, but we really don't have the pre-data to compare it to. But my guess is that that recognition of PDs in clinical settings has gone up as a result of the Axis 1, Axis 2 distinction. And rarely alone. I mean, they're rarely diagnosed alone, but they're diagnosed in relationship to other comorbid disorders. So is that important, or is that clinically relevant to make these disorders as comorbid diagnoses? And I would argue that it is clinically relevant for a number of reasons, and that if you put the PDs back on axis 1, that you would likely reduce their recognition. I mean, I think that already we have the situation where clinicians are inclined to pick one axis 1 diagnosis, whichever one strikes them, the most, or whichever their area of expertise is, or the most prevalent. And yet, even amongst axis 1 disorders, there are important comorbidities that tend to have prognostic or treatment significance. A good one being comorbid anxiety disorder and major depression. And major depression with comorbid anxiety disorder doesn't tend to do as well in most standard treatments as major depression alone. And actually, at one point, the DSM had an exclusion criterion so that you couldn't even make that important comorbid diagnosis according to the DSM rules. So I would worry. I mean, I think that, if you think about it, the only, and it is an important comorbidity, but the only comorbidity that you really see frequently diagnosed amongst axis 1 disorders is between some axis 1 disorder and substance use disorders. That's one that people have really grasped and grabbed onto and run with, and it's very important. Dual diagnosis, schizophrenia and substance abuse disorders, any axis 1 and substance abuse disorders, but you rarely see a lot of comorbid diagnoses being made other than that. And I'm just afraid that if you move the PDs onto axis 1, it would just be an easy way to kind of forget about them. And I don't know. I mean, even though they occur, and think about borderline. I mean, if we're talking about borderline personality disorder and it starts to not be recognized as a comorbid diagnosis, then your affected relative is just going to be bipolar disorder. That's it. I mean, bipolar disorder will get a medication probably, but will they get DBT? I don't think so. Will they get TFP? I don't think so. I think that the patient will be either a bipolar or a PTSD or a substance abuse or an eating disorder, and I'm afraid that will be the end of it, the end of story.
Well, let me comment on that. I think that's a good point. I think that's a very good point, and I think that we need to think about that. But yeah, I see some hands. I'm going to call you in a minute, but I just want to say one other thing. What we need to clarify is that I think they're from a conceptual point of view, I'm not sure there's a strong argument to leave them on a separate axis. From a pragmatic point of view, now you are required to make an axis 2 diagnosis and an axis 1 diagnosis. And I think your point is a very good one, that if we did make the move and put it as another category on axis 1, it might lose that attention and recognition. And there are a lot of data out there that we all know that demonstrate that if you do have, just like with substance abuse, comorbidity of axis 1 and axis 2, that the course of illness, the responses to treatment, there are differences. And there have been studies that have shown that. So I think that's an interesting argument and might add up to a persuasive reason to leave them on that axis. Believe me, the discussion is just starting, so this is going to be an ongoing discussion. We've had hands here. You had a question first.
Maybe outside of looking in, would say, when you guys have here the disease, that it's an affective disease, and one is manifested more with anger and anxiety, other one is more with depression and elation, and you have like two forms of an affective disease. What could be wrong with that? And the story that has been sitting in the board in the personality disorder is emerging now as
So yes. So the question had to do with why isn't borderline personality disorder just a variant of an affective disorder? This would be the Hagop-Akiskal bipolar spectrum disorder concept or whatever, which, by the way, is now, as Harold pointed out, it's now beyond bipolar 2. It's now bipolar 2.5 or 2 3/4 or something like that. I mean, but Hagop will he'll retire before he'll admit that borderline is different than. I actually think that and this is a point that I raised in questions that I made and that Frank Yeomans addressed. I think there's a fundamental difference between the affective disturbance of affective disorders and the borderline personality disorder, and that is this self-other representation disturbance, if you want to call it that. I mean, I don't think that the average bipolar patient responds to themselves, or to in their interpersonal relationships, or to their therapist in any way, shape, or form that resembles the way borderlines respond. And I actually think that if you start to think about what the distinctive, aspects of borderline are, I think it has much more to do with the disturbance of, self and other and the interpersonal side of it than the affective or the impulsive side, which I see as much more sort of a general characteristics that cut across many, axis 1 and axis 2 disorders. And that, that can lead us maybe to a different kind of idea that has been proposed by John Livesley and others of sort of disaggregating, the core features of personality disturbance from the descriptive kind of characteristics that personality disorders and other disorders share, and maybe with that disaggregation, there could be some reorganization of the way PDs were dealt with on axis 1 and axis 2. But I really don't think that we're talking about a variant of mood disorder here. I think we're talking about mood disorder plus something else that's very distinctive.
And if I could just chime in, I agree with that, and I think we have to be careful how we use our words. I think thinking of an endophenotype being affective dysregulation doesn't mean that this is diagnosable mood disorder. It's an engine, it's a motor that's driving a whole cascade of symptoms and behavior, as is impulsivity. And there are reasons that are partly genetic and partly environmental that those problems are underneath. And that, I agree with you. I think that doesn't mean that this is, therefore, a form of mood disorder. So I think we have to keep those distinctions straight. Gene, you had a question.
I would combine the pragmatic with the conceptual. I think keeping axis 1 and axis 2 would be helpful, but within the rubric of personality disorder, in view of the heterogeneity in BPD and the comorbidity with other PDs, why don't we have something new within that and think more along multidimensionality?
So if I understand you, Gene, you would recommend sort of maintaining because of the pragmatic concerns, the personality disorders on a separate axis or category, but address some of the issues of within the personality from a dimensional point of view.
And maybe have reorganized the sets of clusters.
I think that makes sense, and that's that's the direction we need to go. Harold.
I think extending Andy's point about the pragmatics of it is that one of the reasons for access to it at the beginning was to force clinicians to think about personality. And one of the things you also can do on access to is even if someone doesn't have a diagnosable personality disorder, you can get personality traits. So it really gives you an opportunity to focus on personality. And I think there's a strong tendency not to do that. Even now, with residents that
I'm going to do something, if I may, in the context of the concern about the videotape. We can't repeat everything you guys are saying, but we want to catch it. So what I'm going to do is stand up here, use that mic, and then, Kathy, would you be able to circulate this to people who have comments to make and questions, while Andy can repeat Harold's?
Yeah, so Harold was saying that in addition to the diagnosis of personality disorders on Axis 2, the DSM system has encouraged listing or description of personality traits, even if they were not above the threshold for the diagnosis, and that although that might not be commonly done, that that could be very clinically significant, and I would agree with that also. That might again be an argument for a more dimensional approach on Axis 2, whether it's a dimensionalization of existing categories or whether it's a shift towards rating other dimensions, either normal or pathological personality dimensions on Axis 2. That might make the diagnosis of subthreshold PD traits that might be significant more likely. I don't think, I don't know how many people are clinicians in this room, but I do believe that there's a huge difference between treating, say, a patient with major depression who tends to be somewhat dependent versus treating a patient with major depression who's narcissistic or antisocial. It occasionally happens. It's a huge difference in how you would approach the patient. And even if people are listing deferred on Axis 2, my guess is that once they get involved in a treatment with the patient, they're changing their technique or modifying their technique or doing a lot of things with their technique based on how they perceive this person's personality. Too dependent, too obsessive, too narcissistic, too something. And so I think it has a lot of everyday clinical significance. Are they going to take their medications or are they not? I think oftentimes that will depend upon personality differences as much as anything. So I think it's very important, and I think it is encouraged by some sort of Axis 1, Axis 2 separation.
Question in the back.
I appreciate very much those last comments, because that leads into where I was coming from on a pragmatic point. We have enough problems with the restrictions of managed care with single diagnoses. If we have an Axis 2 diagnosis, in addition to an Axis 1 diagnosis, it may over the long haul help us in terms of the financial arrangements to take care of the more complex patient.
I would like to think that was true too, although many people have raised the difficulty of financial payment and reimbursement. Have sort of tried to blame that on Axis 2, saying that somehow Axis 2 disorders are not as important as Axis 1. My solution to that, and we can come back to this, I think personality disorders should be on Axis 1, and all other disorders, clinical disorders, could be on Axis 2.
That's a good point.
Okay. There are a number of other questions. Let me catch John Livesley in the back, and then Pat, I see you in front.
Let me preface my remarks, John, by congratulating you on finding you a path to truth. And I look forward to you following similar paths in future. I think that there are obviously two issues here, one taxonomic and one pragmatic. And I think we are going to have to make some decisions about what the DSM is. Is the DSM just a pragmatic system that is a set of conventions that we use in order to communicate to each other about psychopathology and about patients? If the DSM is just a series of social conventions, it really doesn't matter how it's structured. It's what's convenient and what's useful. But if we think of the DSM, and I think the DSM is largely a set of social constructions at the present time, but if we want the DSM to become a taxonomy of psychopathology, something akin to the taxonomy that biologists use for species, then we want a classification that reflects the biological structure of psychopathology. And so these issues really become important. If we begin to say that there are different classes of disorders, then we're implying fundamental differences. And I think we're fairly clear that there are no fundamental differences between personality disorder and other so-called axis 1 conditions, which is a very strong argument for having a single taxonomy of personality disorder. Now, I recognize there's a lot of pragmatic consequences to that, but I think the path is fairly clear from a theoretical point of view. The practical consequences are, I think, positive and negative. There's no doubt that Spitzer's decision to put personality disorder on axis 2 in 1980 stimulated the field. But it has been at a cost. The cost is that in some jurisdictions, and we have to think just beyond the US sometimes, and the impact that DSM has beyond, that there is an impression being created that there are fundamental differences between personality disorders and other mental disorders, and that does create the basis for the continued stigmatization of personality disorder vis-a-vis other forms of mental disorder. So I think we could also argue that moving personality disorder onto axis 1 may well have practical consequences in terms of clinicians not noticing the condition so much, but it would have other positive consequences in that it would make these conditions more acceptable by making them more like other disorders. We can't hear the sort of stories that you hear in clinical settings. We don't admit people with axis 1 disorders because they're so different we can't treat them, or that we don't treat people with personality disorders because they are different. And I think if we get rid of that, we get rid of some of the stigmatization that occurs. The rest of it, I think, is an educational problem, that we have to educate our clinicians differently. And I'm reluctant to use a taxonomy for educational purposes, but I recognize the problem.
Well, I mean, you know, your thoughts are very sound. I mean, I guess I'd rather. I mean, I'm not sure I'm ready to decide that classification has to be one or the other, taxonomic or pragmatic. I mean, I'd like to think that maybe we could come up with something, you know, that was both. I mean, you obviously would agree and would be a proponent of the fact that, you know, most all of our disorders are conventions that don't, you know, whether they're axis 1 or axis 2, that don't really correspond to, you know, biological reality, and that you know, underlying all disorders are fundamental personality characteristics, traits, proclivities, whether they're impulse, affective, cognitive, etc. And that you know, if we get right down to the biology, we're going to find the biology or the genetics of these traits and these processes, and not, you know, probably hardly any of our existing disorders, even the ones that we tend to really believe in, like schizophrenia or whatever. So, I mean, if you really wanted to have a biological taxonomy, you wouldn't have any categories at all, probably. You know, you would just have basic, you know, mental and emotional and behavioral processes, you know, grouped in some way, shape, or form. But that, you know, that's quite a ways down the road. Again, that would support putting the personality, whatever, on axis 1 and everything else on axis 2 as secondary. But that's another story.
There are also interesting ways in which, because the personality disorders were on axis 2, that they were held to somewhat of a different standard without a systematic process of thinking about whether some of the arguments being made about axis 2 would also apply to axis 1. And what I'm thinking of was a long period of time when there was the state trait discussion about whether, in fact, you could adequately diagnose comorbidity on axis 1 if a patient had a personality disorder, and then the reverse, if you could adequately diagnose axis 2 if a patient was in the throes of a major depression. And that's the one that really took the forefront in the discussion. So let's say you have severely symptomatic major depressive disorder, can you really do an Axis 2 assessment during that episode of depression, or is everything going to be colored dark and all of the Axis 2 reporting will be exaggerated? But what nobody ever wanted to ask, I brought this up many times, was if you think that's true, then there's going to be a similar halo effect for all the rest of Axis 1. So if a patient with severe depression is going to be coloring Axis 2 darkly, he's also going to be over-reporting anxiety, other kinds of symptoms on Axis 1. And there was not a lot of interest in pursuing that, but I think the argument is sound. Pat?
Well,
It's working? Yeah.
Yes. I was just curious why you aren't talking at all about the ICD solution to this, which is to put personality disorder as a class of Axis 1 and retain some kind of dimensional system for the Axis 2. Since it, I'm not, as I say, I'm not a clinician, and I know that people may ignore comorbidities, but probably comorbidities are the most important things to actually look at.
Let me just talk about that. John and I were talking about this also yesterday. And that's a suggestion that has been made as we think ahead for DSM. And so the idea would be to just sort of move the disorders to Axis 1, but retain an Axis 2 that we would redefine in some way as the trait pattern or profile of a given patient. Here's my main problem with that. Well, I have two problems. One is at least the diagnostic manual is a diagnostic manual of mental disorders, and traits are not disorders, so we're introducing something. Now you could argue, well, we've already done that because we've got assessment of level of functioning and other things in there, so okay, I'd go along with that. But the biggest argument, concern I have about that is we have a polythetic system that we're using now. And the polythetic system designates how many criteria you need to have for you to be diagnosed with the disorder. What is our evidence base for that number of criteria for each of the Axis 2 disorders? I would contend that it's zero. We don't have any. This is a clinical consensus that's arrived at based on the best clinical wisdom that could be put together, and hopefully it's an approximately correct level. But we all know that it's somewhat arbitrary and certainly artificial. So if a patient today has 5 criteria for borderline and is diagnosed, and next month drops to 4, is the patient no longer borderline and has no longer a disorder? None of us would buy that. We see fluctuations. These patients, like Axis 1 patients, are environmentally reactive, situationally reactive. We've seen that in the longitudinal studies. So if we're saying that the traits are going to be on an Axis 2, when we don't have a clear recognition of a good reason to have our cutoff points what they are we going to have the patients jumping back and forth from Axis 1, no longer Axis 1, but now sort of on the trait state, or the trait place in the book? And I just feel that that's going to be extremely confusing and so much in need of constant revision as we go forward, as we try to think about what the appropriate cutoff would be. So, I think that's an inherent problem that we have. Now, it could be that if we get to a dimensional system that makes more sense, and we're not using the same threshold-defined polythetic system at this point that we are in the future, that we might be able to go to something like that. But if we use the same system we're using now, that would be my main problem.
Well, you could just establish what you meant by high and low, and it could be, and some of these trait-based systems are have been tested in general populations, whatever, and so you could say it had to be 2 standard deviations above the mean or something like that in a general population. That would be so high neuroticism or low agreeableness or something like that. You could determine that. Now, whether that I agree with you. How whether that was significant or not would yet to be determined clinically significant. I mean, what did it matter? Would it influence outcome or something like that? But I mean, there would be ways of at least designating high and low, and then that would set the stage for trying to decide, do the studies that would test does it have to be 2 standard deviations above the mean, or is 1 enough, or should it be 3, or something like that, I guess.
Paul, Kathy?
I would just like to amplify on something that John said. Speaking as a clinician this time, not as a researcher, I find particularly difficult the construct of remission of borderline personality disorder in short time frames just because a patient falls underneath the threshold for a number of criteria that are established. It's an artificial way of looking at the disorder, and yet both of our wonderful longitudinal studies, the collaborative study and Mary Zanarini's, have fallen into the habit of talking about remission. So personality disorders go into remission, although they can reappear months later if a stressor occurs. So you're already treating the personality disorders in the same terms, the same linguistic terms, maybe even the same conceptual terms as an Axis 1 disorder, but it's not true. It's an artifact of the system, of the polythetic system.
Well, I guess everybody could hear that since you're speaking on the speaker. I don't have to repeat it. The concept of remission of a PD is clearly new and unfamiliar and not what the definition in the DSM would suggest. But first of all, I agree with you. I think falling below the threshold and calling that a remission is not reasonable, and we don't actually do that. I mean, our remissions are much more have even more improvement than just falling below the threshold. In fact, in our collaborative study, whether you're borderline or the other PDs that we study, you have to have 2 or fewer criteria for the disorder for, in one case, 8 consecutive weeks. And the reason that we chose both of those thresholds, 2 or fewer criteria and 8 consecutive weeks, is that is the threshold that was used for remission of major depression. And in our study, major depression without a personality disorder is sort of our comparison group. That's our benchmark. That's the prototypic episodic disorder. And so we wanted to see, well, here's this thing that you call episodic, and here's personality disorder, which is how many of the PD people would actually meet the criteria for remission for major depression. Now, that was one of our criteria for remission. So it's not below threshold. It's 2 or fewer criteria. Then we said, well, that's, when you're talking about personality improvement, I mean, if somebody drops below threshold for a couple of months, I mean, after they report that they've had this thing for years, I mean, is that really significant? So then we said, okay, well, let's look and see whether they dropped to 2 or fewer criteria for a year, consecutive, every month for a year. That's our other definition. So that's also not just dropping below threshold. That's staying there for a year. And even with that definition, we had a fairly significant rate of quote-unquote remission. And I think, someone earlier, John or someone, alluded to the fact that, what we are starting to find or found so far is that, PDs seem to be a mixture of more stable traits that do, in fact, persist at rates close to the rates that we would, identify with stable personality pathology, and then symptomatic behaviors that come and go and that are much more situational, and that there hadn't been any longitudinal studies, including Mary's, that had actually asked people on a monthly basis, did you cut yourself this month? How about next month? How about the month after that and the month after that? And, I think people who have worked with borderline patients or had them in their families would agree that there are crises, that come, and the person is, acting out a lot and manifesting a lot of psychopathology, and then there are quieter periods, and the quieter periods may result from treatment, or they may result from some external change in the person's life or whatever. But it isn't true that every borderline patient cuts themselves every month for, of a 2-year period or a 5-year period or something like that. Even though if you retrospectively ask them, do you cut yourself, they will say, yes, I cut myself frequently, but it may have been 3 times over the last 2 years. And so, again, what we were looking for is like, what is the course of the individual traits? And so some of the traits are in fact there virtually every month. And there's some manifestation of affective, lability, instability, whatever you want to call it, most of the time. But some of the other things that are more behavioral, come and go and seem to be more, situationally determined. So that's sort of the story on, the core, what we're learning about the course of personality disorders. So disaggregating them or thinking about them as hybrids of stable traits and more intermittent symptomatic behaviors is the direction that, our study has been leading us.
I would just also add that, because it's very interesting to think about all of these things and pretty sort of perplexing as well. So if you go just to axis 1 and think about major depressive disorder, well, what's the evidence base that determined that you have to have 2 weeks during which every day you have severe depression in order to meet the diagnosis? I don't think there is any. This was, again, a sort of best clinical consensus you come up with. And if 6 months from now you say no, because actually on the 13th day I perked up because I got some good news, so I didn't make it the full 2 weeks, does that mean you didn't have a depressive episode? So there's a built-in, I think necessary actually, arbitrariness to how we're trying to think about these things. There also is the proposal that there's something called depressive personality disorder that's in the appendix of DSM-4 as something claimed to be a kind of an inherent cognitive style as opposed to a mood symptom phenomenon or syndrome. That's another big debate, but it could be that that's a big picture, broad stroke kind of way of saying maybe there's a trait-like depressive version that's different from an episodic mood disorder. And whether they're related or not, we don't know yet.
Just another comment about the course of the PDs. I mean, the other thing that we can do, and we're now collecting data out around the 8th year and analyzing data around the 6th year, but at the 6th year, I mean, it's clear that some of these people who have had even the longer periods of remission, quote unquote, are relapsing. I mean, are going back to a state where they're meeting criteria again, using the axis 1, axis 2, or the axis 1 terminology. So there's this periodicity, at least, over years that occurs. And so one of the things that we could do would be to look and see, for example, like how many months of, quote unquote, symptom-free period will predict, not remitting or not relapsing versus, are shorter periods of remission, quote unquote, associated with quicker relapse? I mean, is that a pattern that you would see, or is it a more kind of gradual changing thing? So there's never been, as far as I know, the kind of detailed month-to-month data to be able to answer any of these questions as to what's the meaning of these, the clinical meaning of these changes.
John, did you want to make a comment about that? Wait 1 second.
Comment to Paul's comment, because I strongly agree with him. I get very concerned as I read the longitudinal studies, particularly some of them as opposed to others, that comment about remission, which I think makes little sense in that sort of context, given the arbitrary nature. But we're also treating the various criteria as if they are all equivalent, and clearly they're not. I think all of us would agree that a patient who showed a single criterion of identity disturbance would warrant a diagnosis of personality disorder, regardless of whether they met any other criteria or not. So there's clearly an important differences in the criteria themselves that we need to take into account. So just counting criteria just isn't sufficient, and we have to recognize these other components somehow.
While you're there, John, how are you thinking we should proceed with regard to the dimensional model and how that might work?
We're back to whether our classification is concerned with being empirically based and grounded on some sort of underlying biological reality. If we are, then I think there's no option for adopting a dimensional model. The evidence is just absolutely overwhelming and has been for more than a decade that we need a dimensional perspective for lots of reasons. So my thought as we move forward is we have to do that. I think it's absolutely essential that we recognize the dimensional components of the various disorders we're interested in. We focus on those because that's the only way in which we're going to really illuminate both the behavioral aspects of these disorders and the biological aspects. We need to focus on fine detailed traits that we can define fairly precisely as opposed to loosely as we're doing at the present time. So I think at present we're producing a lot of data. I'm not so sure we're producing a lot of facts about personality disorder. As I look forward, I think there's opportunities for integrating various perspectives now. It's going to be very difficult, I think, for people to make a transition from the categorical models of borderline to dimensional models of borderline. So perhaps we can begin to think of integrating the two. So my thought would be we'd move ahead in an ideal world with having personality disorder as a single category on axis 1 and following Pat Cohen's comments, coding personality on axis 2 along the dimensional model. But I think that ideal situation is one we can't move to too quickly. And so I would see us redefining personality disorders presently as categories of trait dimensions. DSM does that, but it doesn't specify the traits. And I think we should just define the various traits of borderline and recognize that. And if we do that, we can use dimensional traits that are part of dimensional models. So we could actually create an integrated classification that satisfies both the categorical approach and the clinician, which also provides the basis for more solid research and which satisfies the requirements of dimensional theories. So I think we're in a point where we could actually integrate the two now, and that's the sort of my preference would be.
So it's interesting. People might want to know that there was a dimensional conference that both John and I attended, one of the sort of pre-DSM-5 planning research conferences, in which there were representatives from the field of schizophrenia, mood disorders, anxiety disorders, substance abuse, personality, and child, I think that was anyway, there were 6 groups represented, where all groups were being challenged with the notion that should they convert their diagnoses into dimensional systems, so that instead of making the diagnosis of schizophrenia, positive and negative symptoms would be rated on continuous measures. In all probably areas of psychopathology, there's some evidence to suggest that dimensional continuous measures are more real than categories. At this meeting, which wasn't attended by David Kupfer or anybody else officially representing the DSM-5, the thought was that DSM-5 would do well to supplement categorical diagnosis with dimensional measures. I mean, that would be, a big step in and of itself. So whether that could be done in each area of the classification remains to be seen. But it is true that PDs are the sort of the test case, because dimensional models of PDs have been around and argued about, and we're sort of ahead of the curve of some of the other areas of the classification. And so if the PD area could get together and come up with either a dimensional model or a combined categorical dimensional model and show that it worked, was useful, was acceptable to clinicians, and so on and so forth, then other areas of psychopathology may follow. Just one other comment. I mean, about your the identity disturbance as sort of pathognomonic of PD. I mean, I think you sort of think the identity disturbance and disturbed interpersonal relations, I think, together, right, are pathognomonic of PD or should be diagnostic of PD. Yeah, so that's interesting to me. You know, I mean, here's somebody from a very different perspective, a genetic, biological, but hardly anybody talks about the core disturbance in personality disorder, except for perhaps the analysts, as being the disturbance of self and other. And I tend to agree. I mean, I think that may be what really separates out personality pathology from a lot of these other related conditions that share features of impulsivity or affective dysregulation or whatever. But anyway, so we're certainly in agreement about that one.
Good.
Maybe I could add that I agree with Frank.
See, this is wonderful. This is
For the
This is
tape,
great.
Dr. Livsley agrees with Dr. Yeomans.
Here we go. Well, I was thinking that in addition to you and Otto, I mean, you could also refer to Bob Cloninger's system, where the TCI system, where to get a personality disorder, you had to have a disturbance of self-determination. So there's the self part, cooperation. There's the other part, and then transcendence. Well, that's a little bit idiosyncratic to Bob, but two of the three, the other two are part of this model. You had mentioned using the SASB and Lorna Benjamin, Drew Weston's model. I mean, the traits from the SWAP that are most consistently associated with PDs and not other disorders tend to be a lot of the self-other traits. So I mean, it's very interesting that these very divergent, and even Marshall Linehan's model. I mean, if you think about the mindfulness part of it, I mean, what is that? Or, I mean, that's very similar to the mentalization concept of Fonagy, or the Kernbergian concepts of self-reflection. So,
Or the old psychoanalytic concept of an observing ego.
Yeah. I mean, it's very interesting that you can come to some, consensus, from very different perspectives about what the fundamental disturbance in PD is.
I think we had a question back there, and then I saw Pat and Frank and maybe others.
Yes, I would like to bring up something that comes from any sort of clinical point of view, and is a real problem with Axis 1 and Axis 2, which is none of the diagnoses give you much predictive validity in designing treatments. Antidepressant, 25-30% response rate, atypical antipsychotic, 25-30% response rate, so forth and so on. Only in certain diagnoses do you have a specific treatment where you have a significantly high response rate. You know what to do. That's a major problem. If this was cardiac medicine, kidney medicine, and you're given diagnoses and you're going, we can do a coin flip and have some idea what treatment's going to be, the public would be looking at you rather concerned. I mean, if you got Wolff-Parkinson-White syndrome, you've got a 95-99% chance to know exactly what to do treatment-wise. That's a real problem now with Axis 1 and Axis 2. What people in clinical practice do, and they end up doing multiple diagnoses, is because they know they're working with extremely complex people with personality, stresses, family problems, environmental problems, social problems, underlying biological things that are going on, and they put together usually fairly complex treatment plans trying to reach a point where they can hit a 90 or 95% response rate. Because, quite frankly, if you're a doctor, you want your people to get better.
Well,
and
I mean,
that needs to be addressed in DSM-5 if possible.
I mean, I would argue that medicine has some non-specific treatments too. I mean, I think diuretics are prescribed for many different clinical disorders that have etiologies that are much better, pathophysiologies that are much better spelled out than our disorders. So they have non-specific treatments. We have non-specific treatments. We're developing specific treatments. So what is DBT? DBT is a very specific treatment at the moment, for borderline and related conditions. So, I think it's possible that we'll continue to develop more specific treatments, but still have to rely on some degrees on non-specific. I mean, the psychopharmacology field could also change dramatically in coming years and come up with much more specific kinds of types of medications that would work in disorder A better than B, C, and D. But we're not there yet.
Well, I would just add that I think it's a very good point, but I think that the differentiation you're making between psychiatry and the rest of medicine, I would also argue with a bit. I think there are very specific treatments for disorders in medicine. That does not mean a given patient you're seeing in the office is going to be the one who's going to respond to that treatment. And if you look at response rates in individual patients, it's a very different matter than results that clearly indicate that a treatment works. We've got a lot of treatments that work. Whether the patient is going to be the one who's responding or who's going to have side effects or who's not going to be adherent to the treatment or all the complexities that go with it. Pat?
I just wanted to express my thoughts about a dimensional axis too, which is that most of the dimensional systems, especially the Big Five that have been proposed, I think, don't have a clear match with the clinical concerns, and that somehow we need to capture the most relevant dimensions for clinical concern in order to have a really good system.
I very much agree. I'm sure you do,
I would
Andy.
agree.
Yeah. Frank?
First of all, John Livesley, can you hear? I just want to thank you for making my day. Appreciate it. But I would also like to say that's why conferences like this are very important, because we learn and I think we integrate. And I wanted to comment on Dixie Ann's talk yesterday, because I found you, Dixie Ann, extraordinarily patient and tolerant when you said that going back 20 years you encountered a lot of lack of knowledge, lack of information, and unsophisticated work, because we're obviously only at a stage along an evolution, and maybe people 20 years from now will be making the kind of comment you made. Yes? But we're talking. Okay. But the point is, I think all of our systems are... Right. All of our systems are evolving. I don't know if they could hear you. But I think it's through dialogue like this that we do advance. And I just wanted to say, though, that my own interests do seem to coincide with some of the later stages of DBT, because I'm hearing everybody knows about the early stage, the skills training, but I have the feeling, too, that the later stages have more to do with what we would consider sort of mental processes, psychological processes. But one thing I want to comment on is that so much of what we're talking about these days has to do with the brain as opposed to the mind. I think it's for many reasons. I think it's because we have ways to study the brain that we didn't have before. I think it's because the brain may have been neglected when the mind was the sole or primary focus. But I think there's a swinging of the pendulum. We're finding that systems that have gone from the mind to the brain are realizing the brain doesn't explain everything either. That might have been a slip. And I think that some of the systems are sort of coming back to rediscovering the mind, and we should just realize that.
Well,
and that might also have a bearing on access, too.
I would say two things myself in response to that. I think Marcia would agree with you that actually that the later stages of her treatment would drift much closer and overlap much with other kinds of treatments. And I've heard her say those very things. And my comment about the mind and the brain is that I actually am coming closer and closer to the argument that the mind is the brain. And I teach a course to our residents about psychotherapy as a biological treatment. And I think we're just learning that we need to speak the same language.
You know, obviously I don't disagree with you about mind and brain, but I do find there are parts of psychological phenomena that are yet far from being explained by the brain, and it has most to do with meaning, with perception, interpretation of meaning, and attribution of meaning. I don't know if you'd agree with that.
I would agree with that. Yeah. Other comments? Here's one right over here. But we're giving Kathy exercise. No.
One, I wondered if you might comment.
Just hold it up here. Yeah.
If you might comment about your book on personality styles and personality disorders, the continuum, or.
Well, thank you for the question and the setup.
You might appreciate it.
This is a book that Lois Morris and I wrote, actually originally in 1990, and amazingly, it's still on the shelves in Borders and Bantam and Barnes & Noble, and it's called The New Personality Self-Portrait. And what I actually did, and this is just an exercise that we did derived from clinical experience, I took the DSM categories of the disorders based on a hypertension or a quantitative model for which there's a fairly good database, and just turned the volume down conceptually until the defined disorders became a non-pathological trait or style, and then devised a self-assessment test that could enable you, sort of MMPI, to chart yourself on the various categories without drawing a line and saying here's pathology above and here's non-pathology below. So it shows what your strongest features are, or traits or styles, and if you don't use the pathology words, you would talk about things like conscientious instead of obsessive compulsive, dramatic instead of histrionic, but using the same kinds of concepts that in too big a dose would become disabling and would lead you into the disorder category. It's an effort without data to try to implement a link between the categorical system and the dimensional system, and a lot of people have found that helpful.
It raises the issue of whether, in thinking about dimensional systems, the personality dimensions, whether pathology is represented by extremes of normal personality or whether there are particular kinds of personality traits that are more pathological than others. Some of the systems that have been around, like the 5-factor model, are sort of normal general personality traits, and the argument has been made, although I don't know that everybody would agree with it, that just elevations on those traits are going to lead to abnormality. But it's not necessarily true. I mean, some extroverts are pathological, and some are entertainers or something like that. So it doesn't seem like it necessarily is the case that it's just a quantitative thing. We've done a study actually that's just recently accepted for publication, where we were looking at different dimensional models as well as DSM categories measured both by categories and dimensions, and how they related to a variety of antecedent, sort of past history, concurrent, and predictive validators. And it's the three systems that we used were the 5-factor model, a more sort of combination normal and abnormal trait system that's embedded in an instrument called the SNAP, which was written by Leanna Clark, similar to John Livesley's DAP, which is another combination of pathological and not pathological traits, and then the DSM diagnoses as diagnoses and categories. And the interesting thing was that when patients presented for clinical care, the DSM diagnoses, but particularly the dimensions based on the diagnoses, were very much associated with important variables at that moment, like dysfunction and so on and so forth. But over time, that relationship got much less strong. The NEO was less, that's the normal 5-factor model, was less associated with factors significant with clinical care when patients presented, but it retained sort of predictive validity better than the categories, or the categories measured as dimension. But the best of all was the combined SNAP model, the model that had both normal and abnormal traits. That both picked up the acute disturbance and the predictive validity 4 years out, things like functioning 4 years out, and course of symptoms, axis 1 disorders 4 years out. And so that combined system, again, sort of pointed to the hybrid. And just as an experiment, this is a Les Morey paper, he took the DSM dimensions and the NEO and made a single dimensional system out of them. So that would be a combination of pathological and normal. And that also demonstrated about as good a predictive validity as the SNAP. So I think that whatever model we come up with, it should be somehow a combination of the pathological traits that will capture the dysfunctions when people, go into the episodes, have the problems that that we all see them when they appear for clinical care, and then the normal traits that seem to have longer term significance. One thought I had about what you were saying, Paul, earlier about remission in personality disorders. I mean, until a few investigators in schizophrenia started to look at schizophrenia in much smaller chunks of time, I don't think people thought that the course of schizophrenia could be benign in certain cases, but it's turned out that it can be. And one of the things we have to guard against is Bergson's bias, which is that we, by definition in clinical settings, always see people at their worst and assume that the disease is as it is, when they present to the hospital or when they present to the clinic. I mean, most of us work in these, tertiary care places anyway that are, way removed from, from primary care, and so we're really seeing people who are on the most severe end of the continuum, and that we really don't know a heck of a lot about, mental disorders that don't appear for care, and we certainly don't know a lot about, personality disorders, out in the community, except for, what we're getting from, Pat's study and others. So I think there's a, a lot of assumptions that have been made that, may need to be rethought, and hopefully people will, continue to look and study and, shed new light.
In the interest of time, I'm going to designate that as Andy's wrap-up sentence and move us on. So let's give Dr. Skodel a hand of applause. You've all been wonderfully attentive and patient and stuck with us through what I think has been just a remarkable 2 days of enormous amount of important information. So I think this has just been a wonderful conference. And I thank all of the presenters, and I'd also, again, like to thank the staff here who've helped, and also the NEA.BPD group for having this agenda to put these conferences on, and there will be more that they will continue to put together. We will try to get this material on the new website that we're putting together for NEA.BPD, so it should be available to you and to lots of others. So if others are interested and weren't able to be here, we'll try to get that in place so that you can reference that and tell people about it. I do want to remind you that for credit to please fill out your evaluation forms.